Welcome back to the deep dive. Today we are doing something a little different and honestly a little intense.
I'd say so.
We are simulating a high-stakes exam prep session. We want you, the listener, to imagine you're an MD anesthesiology postgraduate student getting ready for the Gujarat University exams.
That's right. And we're not just, browsing casually here. We have a serious stack of source material. We're talking Miller's Anesthesia, Morgan and Mikhail, the ARC guidelines.
And of course, the classic S-DOS for the surgical side.
A legend, yes.
And the topic we're tackling today is, well, it's a classic double-header exam question, isn't it?
Oh, absolutely.
We're looking at the anesthetic management of a proximal femur fracture versus a Colles fracture.
And it is a fascinating comparison because it tests two completely different skill sets,
How so?
Well, on one hand, you have the proximal femur fracture. That's usually a geriatric patient, massive systemic implications, very high mortality. It's a medicine case that's just disguised as a surgery.
Right. And then on the other hand, you got the Colles fracture.
Totally different world. Usually a daycare procedure, the focus is on regional anesthesia, high turnover.
So efficiency is key.
Exactly.
Yeah.
But here's the trap. Don't let that minor surgery label fool you. In an exam, they want to see if you can switch gears.
From managing a potential cardiac arrest in the hip case?
To managing efficiency and, specific nerve block complications in the wrist case, it's about mental flexibility.
So our mission today is to distill these thousands of pages into a structured 20-mark answer format. We're going to break it down exactly how you should write it in your answer booklet.
Let's get to work.
Okay, let's start with part A, proximal femur fracture. If I'm sitting in that exam hall, where do I even begin?
You start with the introduction and the exam framing. You have to define your scope immediately. Look, a proximal femur fracture isn't just one thing.
Right.
You must differentiate between intracapsular, that's your neck of femur, and extracapsular.
Which includes the intertrochanteric and subtrochanteric fractures.
Precisely. And that distinction is vital for an anesthetist.
Why does it matter so much to us?
It's all about bleeding and stability. S-DAS highlights this beautifully. Intracapsular fractures. They're inside the joint capsule.
Okay, so the capsule kind of contains things.
It does. It limits the amount of blood that can escape, so they bleed less. But, and this is a big but, they have a very high risk of a vascular necrosis.
Because the blood supply gets torn.
The retinacular vessels, exactly. They get sheared.
Yeah.
Now, contrast that with the extracapsular ones.
So the intertrochanteric.
Yes. They're outside the capsule. The bone there is cancellous, is really vascular. And there's no capsule to tamponade the bleeding.
So that's where the big blood loss happens.
These patients can lose a liter, sometimes 1.5 liters of blood right into their thigh, and you won't see a single drop on the floor.
That is the hidden hemorrhage trap we hear about.
It's a huge trap. And look, if you want to impress the examiner, write in your introduction.
What's his name?
Mention Paul's angle.
Paul's angle. Tell me more.
It's from S-DAS. It just refers to the angle of the fracture line relative to the horizontal plane. The more vertical the line, so a larger angle, the more unstable the fracture is because of shearing forces.
Ah, so it shows you understand the biomechanics, not just the pharmacology.
You've got it. It shows you're thinking like a perioperative physician.
Okay, Paul's angle, noted. Now let's talk about the patient. Who are we dealing with here?
We're talking about the frail elderly. This is a crucial concept. Miller really emphasizes that this isn't just a broken bone, it's a geriatric syndrome.
Meaning what, exactly?
It means these patients have reduced physiological reserve across the board. Cardiac, respiratory, renal, you name it. They're running on empty.
So when an examiner asks why this is such a favorite question...
The answer is that it tests your ability to manage comorbidities. It tests if you can see the whole picture.
Okay.
And here's another tip. This one's for the Viva. Morgan mentions this. You have to differentiate the fall.
You mean ask why they fell?
Yes. Was it a simple mechanical fall? They tripped on a rug. Or was it a syncopal fall?
Like from an arrhythmia, or even a stroke.
Exactly. Did a stroke cause the fall and the fracture? Because if you just treat the hip, but you miss the complete heart block that made them collapse in the first place...
You failed the patient.
And you've almost certainly failed the exam.
That makes perfect sense. And it leads us right into section 2, pathophysiology and systemic effects. You mentioned reduced reserve. Let's really unpack that.
Okay, so in an elderly person, the functional reserve of every organ is diminished. Miller talks about the concept of frailty as a major predictor of mortality. These patients just cannot compensate for stress.
And a hip fracture is about as big a stress as you can get.
It's a massive sympathetic surge. The pain alone dumps a huge amount of catecholamines into their system.
Which means tachycardia,
Yeah.
hypertension.
Which is just awful for an already ischemic heart. You've got a patient with a stiff, non-compliant ventricle, and suddenly you subject them to this catecholamine storm.
And on top of that, you have the occult hemorrhage we just talked about.
Right, so now you have a heart that's working way too hard with not enough fuel in the tank. It's a recipe for disaster.
And this is where the trap comes in. The patient looks stable on arrival because they're so clamped down with vasoconstriction.
Precisely. Their sympathetic tone is cranked to the max just to maintain a blood pressure. Then you, the anesthetist, come along, you induce anesthesia with, say, Propofol.
And you take away that sympathetic drive.
And they crash. You see profound, life-threatening hypotension.
Okay, we can't talk pathophysiology without mentioning fat embolism. This is a very high-yield topic.
It is. The sources, like Morgan and the ARC guidelines, explain that the disruption of those marrow-vascular sinusoids allows fat globules to just pour into the circulation.
Is it just a mechanical blockage, like a cork in a bottle?
No, and that's a key distinction for the exam. There is a mechanical phase, yes, but there's also a very important biochemical phase.
What happens then?
The fat globules get broken down into free fatty acids, and these are directly toxic to the pulmonary endothelium. It causes an inflammatory reaction, almost like an ARDS picture.
So it's not just a clog, it's a chemical burn on the lungs.
That's a great way to put it. It's an inflammatory disaster.
Okay, moving on to what feels like the core of the exam answer. Section 3, preoperative assessment. Everyone talks about the 48-hour rule.
Yes, and the guidelines, ARC, Miller, all of them, they agree. Surgery should ideally happen within 48 hours of the fracture.
Why the rush?
Because mortality, plain and simple, rises significantly if you wait longer. Immobility leads to clots, pneumonia, pressure sores.
But wait, if the patient is really sick, shouldn't we wait a few days and optimize them?
This is probably the biggest trap in the entire exam. The senior examiner will jump on you if you say you want to optimize the patient for a week.
So what's the correct approach?
You delay surgery only for rapidly reversible conditions.
For example?
We're talking about, say, rapid atrial fibrillation that you can control. A severe electrolyte imbalance like life-threatening hyperkalemia, or severe correctable volume depletion.
But not for chronic conditions.
You do not delay for chronic conditions like stable COPD or a bit of anemia. You simply cannot fix a lifetime of lung disease in 2 days. The risks of waiting outweigh the benefits.
So the mantra is, fix the fixable, then get them to theater.
Correct. For these patients, surgery is the best resuscitation. Getting the bone fixed allows them to mobilize, and that's what saved them.
What about specific investigations we should be looking for?
Beyond the basics, you've got to assess their functional status.
Yeah.
Can they climb a flight of stairs? That gives you their METs, their metabolic equivalents.
And if they were bedbound before the fall?
Then you have to assume they have very poor cardiac reserve and plan accordingly.
Miller also emphasizes cognitive assessment.
Yes, this is so important. Do a mini-cog or even just a simple memory test. Ask them the date, their name.
Why is that part of the anesthetic assessment?
Because postoperative delirium is a massive, massive problem with a high mortality. You absolutely need a baseline. If you don't know they were a bit confused before the surgery, you can't properly assess them afterwards.
Got it. Okay, section 4, anesthetic options. This is the great debate, isn't it? Regional versus general anesthesia.
It is. And if you look at the big meta-analyses, the ones cited in Miller and Morgan, the final verdict on mortality.
So death at 30 days or 1 year.
Is that there is no significant difference between the two techniques.
Wow, that's surprising. I feel like everyone just assumes spinals are safer.
It's a very common misconception. Survival is about the same. However, and this is what you must highlight for the exam,
Okay.
regional anesthesia has significant advantages when it comes to morbidity.
And what are those specific advantages?
Well, first, a reduced risk of deep vein thrombosis, DVT. The sympathetic blockade from the spinal causes vasodilation, and that improves blood flow.
Makes sense.
You also see reduced intraoperative blood loss and potentially less early postoperative confusion, although the long-term data on cognitive dysfunction is a bit mixed.
So if I'm sitting in the exam and they ask me to choose, what's the model answer?
The model answer usually leans toward a very carefully managed spinal anesthetic, specifically a unilateral spinal.
A one-sided spinal? Can you explain the technique for that?
Sure. You position the patient with their fractured leg down. I know that sounds counterintuitive and painful, but we'll get to that in a moment.
Okay, fractured side down.
Then you use a very low dose of a hyperbaric or heavy local anesthetic Gravity keeps the block mostly restricted to that operative side.
And the benefit of that is?
You preserve sympathetic tone in the other non-operative leg. And that helps prevent that massive catastrophic drop in blood pressure.
What about contraindications? When do I absolutely have to do a general anesthetic?
Well, patient refusal, obviously. But medically, severe aortic stenosis is the big one.
Why is that?
These patients have a fixed cardiac output. Their heart can only pump so much. If you drop their systemic vascular resistance with the spinal, they simply cannot compensate. They will arrest.
And the other big one would be a coagulopathy.
A huge Viva topic. So many of these patients are on warfarin or clopidogrel. If their INR is high and you can't reverse it quickly, you cannot stick a needle in their back.
Because you risk an epidural hematoma?
Which can be catastrophic.
Yeah.
So in that situation, a GA is your safety net.
This brings us to Section 5, positioning and intraoperative management. You said you put the fractured side down for the spinal. That sounds excruciating.
It is. It absolutely is. Which is why the concept of analgesia before anesthesia is so critical. You don't just wrestle an 85-year-old with a broken hip into position.
So what's the move here? What do you do?
You perform a fascia iliaca block or a femoral nerve block. Ideally, this is done in the holding area or on the trolley before you even move them to the operating table. It makes positioning so much more humane and hemodynamically stable.
And once we're in the procedure, what are the key things to monitor?
Temperature is absolutely vital. These elderly patients lose heat so rapidly. Hypothermia worsens coagulopathy, and it increases infection risk. So a forced air warmer is mandatory.
And hemodynamics, obviously.
Aggressive, proactive treatment of hypotension. Don't wait for it to get low. Anticipate it.
Okay, Section 6, intraoperative complications. We've talked about induction hypotension, but let's get to the really scary one, BCIS, bone cement implantation syndrome.
A Viva favorite. You need to know the definition cold. It's a triad of hypoxia, hypotension, and potentially cardiac arrest, all occurring around the time of cement application.
What is actually happening in the body to cause that?
It's likely a combination of things. First, you get embolization. The surgeon pressurizes the femoral canal with cement, and that forces fat, marrow, and debris into the circulation and to the lungs.
And the second part?
The cement monomer itself, the liquid part, might be a direct vasodilator, causing a drop in blood pressure.
So how do we prevent it? What's the protocol?
Think of it as the Miller protocol. First, high concentration of oxygen. Go to 100% IO2 before they start cementing.
Okay.
Second, ensure the patient is euvolemic. Don't let them be dry. And third, communicate with your surgeon. Ask them to vent the femur, to drill a small hole distally to let the pressure escape.
And if the patient crashes despite all that?
You treat it like acute right heart failure. You support the circulation with fluids and inotropes.
Right. Let's move to the final part for the hip. Section 7, post-operative care. The surgery's over. Are we in the clear?
Not at all.
Yes.
This is where you score the perioperative physician points. Pain management has to be multimodal.
What does that mean?
It means using a combination of things. Paracetamol, nerve blocks, trying to avoid opioids if you can.
Why avoid opioids?
Because they are a primary cause of delirium in the elderly.
And delirium itself?
You should think of it as the fifth vital sign in geriatrics. The causes are multifactorial. Pain, urinary retention from a blocked catheter, hypoxia, and drugs, especially benzodiazepines. Never give an 85-year-old midazolam if you can possibly avoid it.
And what about DVT prophylaxis?
Early mobilization is the absolute key. But chemical prophylaxis, like heparin, needs to be timed very carefully, especially around the removal of an epidural catheter if you've used one.
Okay, that's a very comprehensive look at Part A. That's the heavy topic. Let's shift gears now.
Right, from the hip down to the wrist.
We're on to Part B, Call's fracture. Section 8, Introduction to Call.
Okay, definition first. It's a fracture of the distal radius at the corticocancellous junction with a characteristic dorsal tilt.
The classic dinner fork deformity.
Exactly, as Estes describes it.
And the typical patient.
Usually a postmenopausal woman with osteoporosis,
Yeah.
and the mechanism is almost always a foosh.
A fall on an outstretched hand.
You got it.
All right, Section 9, Anesthetic considerations. How does this differ from the hip fracture?
The biggest difference is the setting. This is very often an ambulatory or daycare surgery, so the goals are completely different.
You're focused on rapid turnover, early discharge.
And minimal postoperative nausea and vomiting, PONV. You want the patient feeling good enough to go home quickly and safely.
But the patient demographic can be quite similar, right? Still an older person?
Yes, and that is the classic trap. Just because it's only a wrist doesn't mean the patient doesn't have the same hypertension, diabetes, or cardiac issues as the hip fracture patient.
So don't skip the pre-op assessment.
Never. Don't skip the cardiac check just because it's a daycare case.
Okay, section 10, anesthetic techniques. This is where it gets very technical. What's the gold standard here for an exam answer?
For exam purposes, you need to know 3 main regional options. But the absolute classic is the Beers block or IVRA.
Intravenous regional anesthesia. Walk us through the Beers block. This is high yield for the practicals.
It's an elegant and cheap technique. You need a special double tourniquet. You exsanguinate the arm, usually with a bandage, to get all the blood out.
Okay, arm is bloodless.
Then you inflate the proximal cuff, the one higher up the arm. Then you inject your local anesthetic, usually lignocaine or prilocaine, into a vein in the hand.
And why the double cuff? What's the point of the second one?
It's for managing tourniquet pain. After about 45 minutes or so, that proximal cuff starts to really hurt.
Right.
So you then inflate the distal cuff, which is now over an anesthetized patch of skin, and then you can deflate the painful proximal cuff. It buys you more time.
Very clever. What's the big safety risk with a Beers block?
In a word, Catalan, last, local anesthetic systemic toxicity.
Meaning?
If that tourniquet fails, or if it's deflated too early,
Yeah.
say before 20 to 30 minutes has passed, you dump a whole bolus of local anesthetic straight into the systemic circulation,
And that goes straight to the heart and brain.
causing seizures, arrhythmias, and cardiac arrest. It's a can't-miss complication.
What about the other options, like a brachial plexus block?
An excellent option. You can do a supraclavicular or an axillary approach. The big advantage here is that the postoperative analgesia lasts for hours, much longer than a Beers block.
And it would be good for a trauma patient, right? Someone with a full stomach.
Perfect for that scenario. You avoid manipulating their airway entirely.
And what about this hematoma block?
Morgan mentions this. It's where you just inject local anesthetic directly into the fracture hematoma itself.
What are the pros and cons?
Well, the pro is that it's simple. Any surgeon can do it in the emergency department.
And the con?
The big one is infection risk. You're technically converting a closed fracture into an open one by sticking a needle in there. And frankly, the analgesia is often patchy and unreliable. It's not the gold standard for your exam answer.
Okay, section 11, tourniquet use. We mentioned tourniquet pain. What actually causes that deep aching pain?
It's thought to be mediated by the unmyelinated C fibers. These are the slow, aching pain fibers, and they are quite resistant to local anesthetic block. That pain breaks through even a good spinal or block after about 60 minutes.
And what about the systemic effects when you let the tourniquet down?
When you release it, you get a washout of metabolic products from the ischemic limb.
Like what?
Lactic acid, potassium, carbon dioxide. This can cause a transient drop in blood pressure and a spike in the end-tidal CO2 reading.
Good to know. Section 12, complications specific to colitis.
The big one to mention is CRPS complex regional pain syndrome. It used to be called Sudeck's atrophy.
What is that?
Morgan notes that colitis fractures have a particularly high risk of this. The patient develops a burning, swollen, red, and exquisitely sensitive hand, often weeks after the injury.
And nerve compression.
Yes, acute carpal tunnel syndrome. The median nerve gets compressed by all the swelling and the hematoma in the carpal tunnel. If the patient has persistent numbness in their thumb and index finger, that's an emergency that might need surgical decompression.
Okay, we have covered the two fractures separately. Now for the synthesis. Section 13. Comparison and exam integration. This is where we bring it all together for that 20-mark answer.
And the best way to score marks here is to tell the examiner you would present this in a table. Visualize it.
Okay, let's build a table. Row 1.
Physiological impact. For the proximal femur fracture, or PFF, it's major, a huge systemic hit. For colitis, it's minor to moderate.
Row 2. Blood loss.
PFF, high and often hidden. Colitis, minimal.
Row 3. Type of admission.
PFF is always inpatient with potential for ICU. Colitis is typically daycare.
And finally, row 4. Analgesia of choice.
For PFF, you're thinking neuraxial blocks or a aphasia iliaca block. For colitis, you're thinking a Beers block or a brachial plexus block.
That is a fantastic high-yield framework. Now, let's talk about Section 14, common exam questions and those dreaded Viva traps. You mentioned the clearance trap earlier.
Yes. You must never tell an examiner you are assessing a patient for fitness for surgery. No 85-year-old with a broken hip and 5 comorbidities is fit.
So what's the correct terminology?
You are assessing them for optimization for surgery. It's a subtle semantic difference, but it shows you understand the urgency and the reality of the situation.
What about the anticoagulant trap?
The classic case. The patient is on clopidogrel with a hip fracture. The guidelines say to wait 5 to 7 days. Do you wait?
I'm guessing no?
Absolutely not. If you wait 7 days, that patient may well die of a pneumonia or a PE in their bed.
So what do you do?
You have a risk-benefit discussion. Often the answer is to proceed with a carefully managed general anesthetic to avoid the neuraxial bleeding risk, rather than waiting.
And the oxygen trap.
It's simple, but common. Forgetting to prescribe supplemental oxygen postoperatively. Hypoxia in the elderly directly causes confusion and delirium. That confusion then leads to them pulling out IV lines or falling out of bed. It's a preventable cascade.
Section 15, diagrams. We need to draw to score well. What should the student sketch?
3 key things. 1, Paul's classification. Just draw the 3 angles to show you understand stability.
Okay.
2, the blood supply of the femoral head. Draw the circumflex femoral arteries and the little retinacular arteries running up the neck. Then draw the fracture line cutting right through them. Label it risk of vascular necrosis.
That's a great visual. And the third one?
Gerd's criteria for fat embolism. Don't try to remember it all. Just draw a box and list the major and minor signs. That's an easy 2 marks right there.
Finally, we're at section 16, the summary and conclusion. Give us the elevator pitch for this entire exam answer. How do you wrap it all up?
Okay, here is your closing argument. You write something like this. The anesthetic management of a proximal femur fracture prioritizes the rapid optimization of limited physiological reserve, the management of occult blood loss, and the prevention of postoperative delirium, with a preference for neuraxial techniques to reduce morbidity.
That's the hip. Now contrast it with the wrist.
In contrast, the management of a Cullis fracture focuses on efficiency, daycare safety, and the application of specific regional techniques like the Beers block to facilitate early and safe discharge.
And the final sentence to tie it all together.
In both scenarios, the anesthetist acts not merely as a technician, but as a perioperative physician, managing the patient's entire systemic response to trauma.
That is powerful stuff. That's a conclusion that scores marks.
Exactly.
Okay, that was a fantastic overview. Let's go back and really dig into a couple of the nuances we maybe skimmed over. I want to go back to the pathophysiology of the proximal femur fracture.
Sure.
You mentioned the stress response, the sympathetic surge. Let's really unpack that for the listener. What does that do to an 80-year-old heart?
Right. So when that bone breaks, the pain is just off the charts. The body dumps adrenaline, noradrenaline. Now picture the typical patient. They have stiff arteries from arteriosclerosis. They almost certainly have some degree of diastolic dysfunction.
Meaning the heart doesn't relax well, it's stiff.
Perfectly put.
Yeah.
It needs more time to fill with blood between beats. But what does that sympathetic surge do? It causes tachycardia.
And it makes the heart beat faster.
That shortens diastole, the filling time. So the heart can't fill properly, cardiac output drops, and the heart muscle itself becomes ischemic because the coronary arteries are perfused during diastole. It is a truly vicious cycle.
So really, pain control isn't just about being humane. It's a critical part of cardiac resuscitation.
100%. Pain control is resuscitation in this context. And that's why a fascia iliaca block done early is so heavily emphasized in all the modern guidelines. It breaks that cycle.
Okay, let's revisit that occult hemorrhage. You threw out a number, 1.5 liters. I just want to confirm that's specifically for the extracapsular fractures.
Yes, specifically for the intertrochanteric or subtrochanteric fractures. The thigh is basically a cylinder. It can hold a massive volume of blood before it looks grossly swollen to the naked eye.
Estes says to compare the girth of the 2 thighs.
You should. But the real trap for the anesthetist is relying on that initial hemoglobin level.
Why is that?
The patient bleeds whole blood red cells and plasma. So the concentration of hemoglobin can look deceptively normal at first. It's only after you start giving them IV fluids and you dilute what's left that you see the HB plummet.
So if you induce anesthesia on a patient with a normal HB who is actually profoundly volume depleted,
their blood pressure will just fall off a cliff. You have to assume they are hypovolemic until proven otherwise. Always.
Okay, and one more pass at fat embolism syndrome. We listed the criteria, but what does it actually look like in the operating room in real time?
It can be very subtle, or it can be catastrophic. The first thing you might see in the OR is on your monitor. Your end-tidal CO2 will suddenly drop.
And why is that?
Because the fat emboli are blocking the pulmonary circulation. You're still ventilating the lungs, but there's no blood flow to pick up the CO2. It's an increase in dead space.
And at the same time, the SpO2 drops.
Right. And if the patient happens to be awake, say under a spinal, they might suddenly become very agitated, confused, or breathless. Later, post-op, you look for that classic petechial rash.
The little red spots on the armpits and the eyes?
Exactly. It's a key diagnostic sign.
You've sold me on the unilateral spinal, but it sounds technically tricky. How do you really ensure it stays on one side?
It really is all about understanding baricity and using gravity. Bupivacaine, the common spinal drug, can be made hyperbaric, heavier than spinal fluid, or hypobaric, which is lighter.
So you're using its weight.
Precisely. The standard technique is to use hyperbaric bupivacaine. You place the patient in the lateral position with the fractured side down. The heavy drug sinks and settles onto the nerves on that dependent side.
How long do you keep them there?
About 10 to 15 minutes. That gives the drug time to bind to the nerve roots on that side. The result is a great block on the bad leg with minimal block and preserved sympathetic tone on the good leg.
Which keeps the blood pressure up, a very pro tip.
Oh,
Let's pivot back to colitis for a moment. The beer's block safety. You mentioned last. What are the very first signs we should be looking for?
if the patient is awake, the very first things are often sensory. A metallic taste in the mouth, ringing in the ears, tinnitus, numbness around the lips.
And then it progresses.
Then you might see agitation, slurred speech, then seizures, and finally cardiovascular collapse.
And the treatment for that is lipid rescue.
Yes. Intralipid 20%. It acts as a sort of lipid sink to mop up the local anesthetic from the bloodstream. Every single location that performs Beer's blocks must have a bag of intralipid immediately available. It is a non-negotiable safety check.
Okay, final viva voce simulation. I'm the examiner. Candidate, you're assessing an 85-year-old for a hip screw. She has a heart murmur. What are you thinking?
Sir, my first priority is to characterize that murmur. My main concern is aortic stenosis. I would look for the clinical signs, a slow rising pulse, a narrow pulse pressure. I would urgently request a recent echocardiogram report. If it confirms severe aortic stenosis, I would be extremely cautious with neuraxial anesthesia due to the risk of cardiovascular collapse in a fixed cardiac output state. I would prioritize invasive monitoring like an arterial line and focus on maintaining systemic vascular resistance.
Good. She's also on aspirin and clopidogrel. Her last dose was yesterday. What do you do?
Sir, neuraxial anesthesia is contraindicated due to the high risk of an epidural hematoma. While guidelines suggest waiting 5-7 days for clopidogrel to wear off, we cannot delay hip surgery that long due to the significant increase in mortality. Therefore, the safest course of action is to proceed with a carefully managed general anesthetic, paying close attention to airway management and hemodynamic control. I would not delay the surgery.
Excellent. That's exactly the kind of confident, reasoned answer they want to hear.
It's about balancing risks.
And one final thought. You mentioned nutrition and the orthogeriatric concept. Why should an anesthetist bring that up?
Because the best outcomes come from a holistic, team-based approach. These patients are incredibly catabolic. They lose muscle mass so quickly. Early feeding, a good bowel regimen, and co-management with a geriatrician are all part of the modern standard of care. Mentioning the multidisciplinary team in your conclusion is always a winner.
It shows you're thinking beyond the operating room.
You're thinking about the entire patient journey.
So, a final checklist for our listener. 1. Be precise with your definitions. 2. Focus on the physiology of the frail elderly. 3. Know the RA versus GA debate. 4. Know your safety protocols for BCIS and tourniquets. And 5. Use a comparison table.
And remember your sources. Miller for the deep physiology, Morgan for the block techniques, Esdas for the clinical context. If you can ground your answers in those texts, you cannot go wrong.
To our listener who's preparing for the exams, visualize yourself writing these headers in the answer book. Draw those diagrams in your mind. You have all the knowledge. It's about structuring it now. Good luck with the exam.
Go get those marks. You've got this. Good luck.